Professor Abdul Qadir. He's a professor of medicine in Muhammad Medical College, Mirpur Khas. Welcome all to this session, and let's begin with the first case. The first case will be presented by Dr. Faisal Waseem Ismal, and Dr. Faisal is an associate professor of gastroenterology at the Aga Khan University Hospital, and he will be presenting a case of gastric variceal hemorrhage when endoscopic management has failed. So over to you, Dr. Faisal.
Assalamu alaikum and good afternoon, ladies and gentlemen. Welcome to the case vignette areas presentations of the PSSLD. The case given to me is a case of gastric variceal hemorrhage when endoscopic management fails. I want to start off by telling you that the resources that I have used for this presentation are from these three important papers which deal particularly with gastric varices. And so if you want, you're welcome to read these in more detail to get a better understanding of the management of gastric varices. So I'll start off with the case. This is a 52-year-old male, a known case of hepatitis C related chronic liver disease who's presented with hematemesis for 8 hours. He's also complaining of 2 episodes of melena that have happened in this time. He has a previous history of endoscopic variceal band ligation for an upper GI bleed 2 years ago. He has been on a PPI and a multivitamin, but no other medication. So he comes in, you look at his labs, you resuscitate him, and then you proceed with an EGD. And this is something that we found many times. You go in, you see a large varix, you also see a small ulcer and a rent on the varix, which tells you that this is possibly the site of the bleeding. But you'll notice that there's not a lot of blood, so you feel comfortable in doing endoscopic therapy here with a sclerosant. What you do, and this is what happens, it starts to bleed and then it just continues to bleed. There's this fountain of blood that's coming out, and regardless of what you do, you're not able to control it. So this is gastric variceal hemorrhage when endoscopic therapy has failed. And when we say failed and when we say endoscopic therapy, what I'm assuming for the purpose of this talk is that even EUS-based therapies, which you can actually target the varix under EUS, has also failed because EUS is also endoscopic therapy. So for the purpose of this talk, I'm assuming that all endoscopic therapies have now failed. So what is available to you as a physician? Well, before we go on, just a quick classification of Sarin's classification of esophageal gastric varices. You all know this, where GOV1s are esophageal gastric varices extending into the esophagus and onto the lesser curve. GOV2 are those that extend onto the greater curve. Then purely gastric varices are divided into 2. There's IGV1, which are in the fundus right over here, and IGV2 in other parts of the stomach. And there are ectopic varices, which are mostly in the duodenum, but can be in other parts of the gastric tract as well. So for the purpose of this talk, we are confining ourselves to, if you look at the screen on this part of the therapy, which is when you have done the glue injection and you've not been able to control it. So as per current guidelines, these are the following options that are available to you, which I'll be talking about in the next few minutes. So the first is balloon tamponade. So what do we know about balloon tamponade? We know that it's a good rescue measure, but that's really about all. Most guidelines describe this as only effective short-term measure. Currently 3 tubes available. The most commonly used is the Sengstack and Blackmore tube, which has 2 balloons, a gastric and an esophageal balloon and a suction port. Then there's the Minnesota tube, which is a modification of the Sengstack and Blackmore tube, but it also has an esophageal suction port. And the Lenton Nachlas tube, which is a smaller tube, which is just a single gastric balloon, not an esophageal port. Now, their use has decreased over time because we are better now in controlling gastric variceal bleeding with endoscopic and pharmacological measures. Most studies regarding balloon tamponade relate to esophageal variceal bleeding. So this is a problem when you try to extrapolate that data to gastric variceal control. There has been one study that's found initial success rates of in the high 80s with the use of balloon tamponade. But we need to remember that there are significant complications that are associated with this, including esophageal ulcerations, necrosis, rupture, and aspiration pneumonia. And that is why it's really not recommended for you to use balloon tamponade measures if you are not used to using them and if there are better modalities available. At this time, guidelines would just tell you to use balloon tamponade measures as just a small bridge to TIPS, which is what I'll be talking about right now. So TIPS is widely used as a salvage option for gastric variceal bleeding. In the West, it's actually been used as first-line treatment for gastric varices once they have been noted on a screening endoscopy. TIPS has been shown to be successful many years ago. The first study was in 1998 that showed TIPS was good for uncontrolled gastric variceal bleeding, which is what we are talking about. So that established its role, and but it's also important to understand that TIPS in gastric variceal bleeding remains difficult. Most studies have still used TIPS as a modality for uncontrolled esophageal variceal bleeding, which is not the same as gastric variceal bleeding, and a lot of studies have actually excluded gastric varices in patients when looking at bleeding control for varices. This is what we do in a TIPS, and of course all of you know this, but just to revise, we go in through the transjugular route, and you put an intrahepatic portosystemic shunt by putting in a shunt between a branch of the hepatic vein and a branch of the portal vein that can shunt the blood through the portal vein over here and therefore decrease portal pressures. The problem is that TIPS is not widely available. There have been studies comparing cyanoacrylate glue, the histoacryl that we inject into gastric varices versus TIPS. And generally it's shown that there is no difference in rebleeding rates. That means cyanoacrylate works very well in patients with fundal varices. But when you are dealing with and failed endoscopic therapy, then guidelines suggest that TIPS should be your next choice in case of failure of glue therapy in uncontrolled gastric variceal hemorrhage. What about balloon-occluded retrograde transvenous obliteration, or BRTO? Now, BRTO is an intervention radiology technique which accesses gastric varices through a gastrorenal shunt, which is extremely important, that a gastrorenal shunt needs to be present for BRTO to work. And once you go into this shunt, then you occlude it with the balloon, and then upstream of the balloon, you inject the sclerosant, which is injected into the gastric varices. Many retrospective reports showing it's worked very well, but no real good prospective randomized trial. But it's difficult to do a prospective trial around this as well, simply because gastric varices are not as common as esophageal varices, and in most cases, glue therapy works. When you compare BRTO to TIPS, BRTO is equally effective or even superior to TIPS, but remember this is retrospective data. But a recent meta-analysis taking into account 6 studies have shown that virtually BRTO is good across all things for decreasing mortality rate and a lower bleeding risk and encephalopathy risk as well compared to TIPS. This is what happens in BRTO. You access a systemic vein either through the internal jugular, most likely the femoral, and what you need to do or try to do is get into the left renal vein and try to access the gastrorenal shunt over here. But sometimes if this doesn't happen, you can even go into the splenic vein as well. But what you need to do is try to get into the gastric vein that is draining these esophageal varices, the gastric varices. You inflate a balloon over here to block the outflow. Once you've blocked the outflow, you need to also block other channels that may be serving as outflow track as well, and a lot of the time coils have been used, gel foam has been used to block this as well, and then you inject the sclerosant upstream into the gastric varices. The sclerosant that has normally been used has been ethanolamine oleate, but and butyl-2 cyanoacrylate has also been used with good effect. Coils have been used. Essentially, all those elements that have been shown to occlude bleeding vessels can be used over here. You keep this occluded until the time the sclerosant takes place and the varix is obliterated. So it works very well. There's good data to show that it works, and it's especially meant for those people where TIPS is contraindicated, such as advanced liver failure or hepatic encephalopathy, because as most of you will know, hepatic encephalopathy is a contraindication to TIPS because the shunting of blood from the portal system to the venous, to the main system, virtually always causes some degree of encephalopathy. So if your patients have been encephalopathic before or have a tendency because of the advanced liver disease to become encephalopathic, then I would encourage you not to use TIPS, and if available, consider BRTO. Finally, surgery is applicable, but it's only applicable in highly specialized centers. This consists of selective shunts and very carefully selected patients. You can understand subjecting a patient with child C cirrhosis to surgery is almost a death sentence for these patients. So it's got to be the carefully selected patient whose child's A, who has large varices, which he's bleeding from, which you're not able to control. Otherwise, the risk of complications is just unacceptably high. In cases of segmental portal hypertension, for example, your occasional patient, for example, with splenic vein thrombosis, secondary to acute pancreatitis, for example, splenectomy and those shuntings, surgery can be considered, but otherwise surgery is in the very rare patient with cirrhosis who has uncontrolled gastric variceal bleeding, which is not being controlled. So to conclude, intervention radiology options are indeed your possible only option when you're dealing with a patient where endoscopic treatment has failed in gastric variceal hemorrhage. We all understand, having seen these patients, that this is catastrophic bleeding, this is very rapid bleeding, and we need to do things very quickly. In such cases, if you have a balloon, if you have a Sengstack and Blackmore tube or any of the other balloons that you know how to use, then you can use it as a small bridging measure. But remember, because balloon tamponade is limited by availability, not all units have them. Expertise in usage, you don't want to use it if you haven't ever used it before and you don't know how to use it, because the complication risks are very high. You should try to use TIPS immediately if you can. TIPS is where the best data is to show that it works for these patients. And if TIPS is contraindication, BRTO should be used if your expertise is available. Thank you.
Thank you, Dr. Faisal. I would request you to please stay online because we'll have the question and answer session at the end of the symposium. I would like to request the audience to please type their questions in the chat box so that we can have them and we can have the questions from the experts. So with this, we move on to our next case, another important and interesting case, this one. And this will be presented by Professor Arif Amir Nawaz. Professor Nawaz is a consultant gastroenterologist and hepatologist at Fatma Memorial Hospital, Lahore. And he would be presenting something on acute liver failure, which is due to Budd-Chiari syndrome. Professor Arif Nawaz.
Assalamu alaikum. For people who have been paying attention, this is a slightly different setup now because ये live talk है. So I might pause a couple of times during my presentation, and आपका जो response हो उस पे जो question पूछा जाए, you can easily send it on the text just for some interest. So this is a case of acute liver failure due to Budd-Chiari syndrome, and what I'll try and do here, the objectives of this, oops, all right, I can't see that image, but I'll just move on to the next slide. The objective of this talk was basically a brief overview of definition and etiology of acute liver failure. I'll talk about the etiology, spectrum, clinical presentation of Budd-Chiari syndrome. And once I'm done, you will realize that there were a lot of cases that you should have thought of Budd-Chiari and you did not. And there's a brief overview of management of Budd-Chiari. I'm not going to get into that. It's a very, very complex thing. But I want to emphasize the clinical presentation and how you look for this. Okay, so this is a 24-year-old mother of one child who actually presented to the ER with deepening jaundice. She also had abdominal distension, drowsiness of 6 weeks duration. She delivered about 2 months ago but had an unremarkable obstetrical history. She reported her symptoms had begun with crampy abdominal pain located in the right upper quadrant. nausea, vomiting, jaundice, and progressively increasing abdominal girth. Physical examination reveals jaundice, drowsiness, flapping tremors, shifting dullness, and lower extremity edema. To summarize this is a case of acute liver failure presenting with recent pregnancy, right upper quadrant pain, and ascites. Any quick thoughts on this? Let's get you simulated right after lunch. Actually, we have had a very heavy lunch today. We will keep on going. Now, the differential of this particular case, you would think of infectious hepatitis. She has recently delivered. She's a little far out from pregnancy, but in our setup, you do see a lot of acute Hep E along with this. Medications would be the other things, any overdose. Budd-Chiari would definitely fit in there, and the reason I say that is because she does have abdominal distension, ascites, right upper quadrant pain, so it should be a thought, and then Wilson's disease, again, can present at any stage with acute liver failure. Now, what is acute liver failure? It's basically development of severe acute liver injury with encephalopathy and impaired synthetic function, INR of more than 1.5, in a patient without cirrhosis or pre-existing liver disease. Now, the commonly used cutoff is less than 26 weeks. Now, there are certain conditions where you could have underlying liver disease, but the disease presentation is again less than 26 weeks. And things like Wilson's disease, vertically acquired Hep B, or autoimmune hepatitis. And patients with acute severe alcoholic hepatitis, if they are recognized even for less than 26 weeks, we consider that as acute on chronic liver failure. And that's because we think they do have some underlying liver disease even before that. Now, within the acute liver failure, the reason I'm giving you this overview is it will just help me then put BCS in perspective. Hyperacute is less than 7 days. The cerebral edema is very common in these people, and in the West, this would usually be acetaminophen toxicity. Acute is between 7 to 21 days, and there is cerebral edema there. Then you have subacute, which is between 21 days and less than 26 weeks. And renal failure and portal hypertension will be more common in there. There's some very good talks coming up on these tomorrow in the acute liver failure. Now, just to give you a very broad idea, drug-induced liver injury is the most common cause of acute liver failure in Australia, Europe, UK, and the United States. Viral hepatitis predominates in our part of the world. Now, the most important thing here is we need to have a diagnosis. There are certain treatable conditions, including some with BCS, that if you get the diagnosis right and quickly, these people can be saved. Now, this person's labs come back, and I'm going to leave this on for a couple of extra seconds for you to think now. So here's a patient with right upper quadrant pain, edema, ascites, encephalopathy, has a coagulopathy, INR is 1.9, platelet count is low, bilirubin is 12, transaminase is way high there, creatinine is high, 2.5, viral workup is negative. The ultrasound gives us some clue about prominent hepatic caudate lobe, hypertrophy of the left liver lobe, and the aesthetic tab reveals a high sag. And I think your brain has started thinking now, and this, I'll show you what we think this is going on here. So here are the clues again: young age, negative liver workup, recent pregnancy, high sag, imaging showing a prominent hepatic caudate lobe and hypertrophy of the left lobe, right upper quadrant pain, ascites. If you put this all together, you must have seen a lot of these cases. I don't think before this presentation a lot of us would have thought about BCS, but that would definitely be up there if you have a person like this. Now, this patient was admitted to the ICU. Unfortunately, she did improve initially. Transaminase came down, which may not be a good sign always. The INR improved slightly, but then she worsened and she died. So she really had a very fulminant course. So Budd-Chiari syndrome, now to put everything in perspective, this was a case of Budd-Chiari. It is included in the differential diagnosis of acute liver failure, acute hepatitis, and chronic liver disease. So if I can get this message across to you that you should think of this vascular disease of the liver in almost all very sick liver patients. Now, what is Budd-Chiari? It's basically hepatic venous outflow obstruction, and it is independent of the level or mechanism of obstruction. Provided the obstruction is not, these two things have been excluded due to cardiac disease, pericardial disease, or sinusoidal obstruction syndrome, which is called the veno-occlusive disease of the liver. Primary BCS occurs when you have an obstruction due to a predominantly venous process. But when secondary BCS is when there's compression or invasion of the hepatic veins or IVC from outside of the vein, for example, malignancy. So there are other causes, and I mentioned these two: sinusoidal obstruction syndrome, which is hepatic veno-occlusive disease, or right-sided heart failure. These will not be considered BCS. So epidemiologically, Budd-Chiari in our part of the world is slightly different from the West. We get more male preponderance, and the age group is a little older at 45 years, and it's basically mostly hepatic blockage. In the West, it's usually a combination of IVC and hepatic vein blockages. This is again a busy slide, and I'm going to go through these causes of the Budd-Chiari syndrome in a second, so I'm not going to stay on this slide for too long. So etiology of Budd-Chiari syndrome, the first one I'm going to talk about is hypercoagulable states. You should be always thinking of them. A cause is usually identified in more than 80% of the patients. About half of them would have more than one cause. 50% of all cases of BCS are due to chronic myeloproliferative disorders. Always keep polycythemia vera, essential thrombocythemia, and all these things in mind. This workup should be sent. One caveat here is that these patients may not have evidence of myeloproliferation because they have portal hypertension, they have splenomegaly. Now this JAK2 mutation should be sent on all these patients, because sometimes you may not have blood evidence of myeloproliferative disorders in other blood tests, but you will find it here. Factor V laden gene mutation, this occurs in about 1/4 of the patients, and it should be looked for. And the one that we have always talked about a lot, but really they are not as common, are the antiphospholipid antibody syndrome, protein C and protein S in the context of BCS. About 10% of the patients are because of Budd-Chiari, of Budd-Chiari syndrome, or because of a malignancy, and hepatocellular carcinoma is one of the most common ones. So whenever you see Budd-Chiari, you should be looking for an underlying etiology, and that's what I just discussed. Other than that, benign lesions, they will cause about 10% of this. So think of hepatic cysts, hepatic adenomas, cystadenomas, and so on. Now, about 1/5 of the cases of BCS are because of pregnancy or oral contraceptives or even postpartum, and I think we should, and the hypercoagulable state in these women should always be considered. Behçet syndrome, again some kind of an exam question that my younger colleagues are going to see. And membranous webs in our setting become particularly relevant, and the reason they are relevant is because they are very easy, they're very treatable, and we just had a IR person give us a very nice review. So the expertise for dealing with these is there. Other than that, SLE, mixed connective tissue disorders, and so on. Now, what do they present with? I'm going to re-emphasize: fever, abdominal pain, abdominal distension, lower extremity edema, jaundice, GI bleeding, and so on. But remember what I told you in the beginning. There are in three conditions you would always consider this: acute liver failure, acute hepatitis, or even chronic liver disease, because some of these things can present to you very late. Now, how do we categorize Budd-Chiari? There's acute, which is about 5% of patients, like our patient went downhill very quickly, high INR, hepatic encephalopathy, and so on. Acute, which is about 1/5 of the cases, and they progress over weeks. They have intractable ascites and hepatic necrosis. And then subacute, which takes up to 3 months to develop, and ascites and hepatic necrosis may be minimal because they form collaterals. And then there's chronic patient who presents with chronic liver disease and cirrhosis. Diagnosis: Doppler ultrasonography is an excellent test. CT I'm not emphasizing too much, but although it is used, and the reason there is because of the renal insufficiency these people tend to have. Venography is really indicated unless you're planning a therapeutic procedure. And how do you manage this? It again depends on the clinical presentation, anatomical features, as well as the local expertise. Anticoagulation, unless there is an absolute contraindication, must be given to all these patients. Attempt should be made to restore patency of the thrombosed veins, and angioplasty, stenting in the case of the membranes. You can try that. Then tips, surgical shunting, and I'm not going to dwell on the management. I just wanted to present basically the clinical scenario to you, and prevent or manage complications with treatment of portal hypertension and liver transplantation. Now, each of these cases needs individualized treatment, anticoagulation to everybody. Liver transplant is usually, these people go when they have an underlying hematological disorder, the liver is cirrhotic, or if this comes on too quickly to manage. Now, for the people who have kids, this is a little slide to wrap my presentation up. They are not used to going to school, so when they do, inshallah, start going to a physical school, they will always raise the question, why do I have to go? Why can't I just log in? And it's like most of us also now. And one last thing I want to finish with a little Sufiana poetry for people who have sort of dozed off. Bure bande nu main labban turiya par bura labba na koi. So the guy, he says, the Sufi says that he went to look for a person who was, not the right person, but he couldn't find anybody. Jad main andar chati pai te main to bura na koi. When I looked into myself, I didn't find anybody worse than me. So always be looking for this. This is a 400-year-old poetry from our Sufis. So thank you very much. Thank you, and thanks the organizers for this excellent meeting.
Thank you, Dr. Arif, for an excellent review. And I think this was a great touch with a Sufi touch as well. So right. So still waiting for the questions in the chat box. With this, we move on to the next talk. Okay. So, right, Dr. Sadik is probably not online. So we'll skip this, and I think we can come back to it later on. So yes, so starting with another important and imperative talk, and this is this session. This case would be presented by Dr. Yasir Abbas Zaidi. Dr. Yasir is Assistant Professor Gastroenterology at Nishtar Medical College, Mr. Medical University, Multan, and he would be discussing a case, a very common scenario, day-to-day life, a patient with cirrhosis who has been planned for laparatomy. And actually this will deal with pre-op evaluation of patients with liver cirrhosis. So over to you, Dr. Yasir.
Bismillahirrahmanirrahim. I am Dr. Yasir Abbas Zaidi. I am working as Assistant Professor of Gastroenterology at Nishtar Medical University, Multan. On behalf of Pakistan Society of Study of the Liver Diseases, I would like to welcome you all on this 14th annual conference titled Quick Decisions in Hepatology. This segment is planned for a clinical vignette, which I'm going to present in front of you. The title is A Patient with Cirrhosis Planned for Laparatomy. So before we start, as always, I begin all my presentations with this picture, which shows my alma mater, where I was born and I was trained to what I am right now. The learning objectives of this clinical vignette will be effects of surgery and anesthesia on liver, estimation of operative risk, and risk with specific type of surgery, choice of sedatives for endoscopy/surgery in patients with liver disease. So we start with a clinical scenario. This clinical scenario will include our very own imaginary patient called Mickey. He's a 45-year-old male with previous history of chronic hepatitis, presenting to the accident and emergency department with high-grade fever, abdominal distension, inability to pass wind, and persistent vomiting for the last 2 days. He was immediately referred to the surgical ER with provisional diagnosis of acute abdomen. Surgeons started rushing towards the patient until they found out that the patient is cirrhotic, and they backed off and decided to postpone till the next day to be given a trial of conservative management. His past history included 5 years history of chronic hepatitis C, which was treated 4 years back with oral antivirals, and he achieved ETR and SVR. The record was available. His laboratory findings were as follows. His hemoglobin was 10.5 grams, TLC was 11,000, and platelet count was 150,000. Serology included a positive anti-HCV with a negative hepatitis B surface antigen, bilirubin of 1.5, ALT 65, and AST of 85. Serum albumin was 2.8, and PT-INR was 1.8. His ultrasound abdomen revealed mildly cold liver with splenomegaly and mild ascites. His CT scan was done subsequently, which revealed similar findings of coarse liver with mild to moderate splenomegaly, mild ascites, small perigastric varices. Bowel wall showed dilated small bowel loops with multiple air fluid levels, but no obstructive pathology could be located. Now the million-dollar question. Mickey seems surprised right now that what to do next. As always, the knee-jerk reflex, call to gastroenterology. And the surgeon's question would be to open or not to open. So let's take a few seconds and think about it. This is a 45-year-old male and with the chronic liver disease having a surgical emergency of acute abdomen, and he needs surgery. The gastroenterology team rushes to the rescue, and now the major questions which are in our mind right now: is the surgery absolutely necessary? Can it be managed conservatively? And if not, is it safe to open, and what will be the post-surgical outcome? This scenario we run into almost every day, and these are the questions that are running through my mind. But belonging to our side of social bonding that we have certain dilemmas at our hand, which are in addition to the medical risks. The family insists for surgery, and while if we go for surgery, we risk losing the patient if we decide not to go for surgery. If surgery is done, then what will be the post-surgical outcome, and will the patient be able to handle the surgical / post-surgical stress? So what do? Our residents come rushing to us that we have this problem. What should be our next step? So the things or tools that we have right now are our very own Mayo Risk Score, MELD and MELD NA, or the modified MELD score, or the Child Tuck or Pew scoring. In addition, recently in the recent AASLD, another score called the Vocal Pen score, which is called the Veterans Outcome and Cost Associated with Liver Disease. This has shown to outperform the sensitivity and specificity of predictive capability of Mayo Risk and as well as the MELD score. As we all know, that post-operative liver dysfunction is a pretty common thing. Usually, it is mild if the patient decides to go. We decide to undergo the surgery. But we all know all anesthetics can cause this. The risk of decompensation of pre-existing liver disease, susceptibility to hypoxemia and hypertension, hyperdynamic circulation, reduced portal blood flow, and impaired hepatic arterial autoregulation. Whatever the choice of anesthetic may be, this is going to pose a major surgical risk to the patient, as all anesthetics are known to compromise the liver circulation. Now, the post-operative hepatic dysfunction can range from cholestasis. It can be ischemic hepatitis associated with any surgical risk or circulatory dysfunction, or acute and chronic liver failure, which may be due to any surgical or any drug or overall stress-related. There can be reduced hepatic oxygenation, which can be due to hypotension, shock, hemorrhage, hypoxemia, heart failure, vasoconstrictive drugs, traction, and recently it has been found that during surgery, traction on viscera, that creates another form of dysfunction in such patients. Now, when we decide to go for surgery in liver disease, we should keep in mind certain absolute contraindications when surgery should not be undertaken. If there is acute liver failure, acute viral hepatitis, or acute alcoholic hepatitis. Having said that, the type of surgery comes into play next. Either it's a major surgery, or it's a minor surgery, or it's a minimally invasive surgery. Then we go to another point, which says that we have to look for risk versus benefit. Either if this surgery is emergency surgery, then it is absolutely necessary to undergo that. But if it's if it is an elective surgery, then we have a choice. We can wait. We can give a trial of conservative management, but at the same time we risk we risk losing the patient to his original disease, while the added benefit is that we can optimize the patient and improve the surgical outcome. I'll shed some light on it later on. While the patient is being decided for liver surgery, the risk factors include emergencies. If it's an emergency surgery, it's a risk factor. Biliary surgeries, COPD, malnutrition, coagulopathy, anemia, ascites, encephalopathy, high child and MELD score. These have been related directly to a poor surgical outcome in a cirrhotic patient. So, while searching for literature, I came across this slide from which was taken from ACG 2016, where a study which was done in 1984, which included 100 cirrhotics, and which was a retrospective study where risk factors were ascites, infection, malnutrition, bilirubin, emergency surgery, albumin, and high child class. Multivariate analysis was done, which initially included albumin, infection, and PT, but excluded the child class. Here, it was found that the mortality and morbidity associated only with the liver disease was in excess of 30%. And when they included child class, because they found out that child class was directly influencing or pointing towards our post-surgical outcome directly. So, according to this study, the operative mortality in the child class A patient was 10%, in child class B it was 31%, and in child class C it was 76%. Surgical morbidity and mortality in cirrhosis. This time, I found a study published in 2010. Here we see a drastic change. The post-operative mortality has plummeted down to, in child class A to 2%. And in child class B and C, it has managed to stay at around 12%, which is pretty acceptable in this case. So, operative guidelines in relation to these studies, these would say that in child class A, we have a good operability chance. In child class B, it's tolerable, but if we prepare good, you can have a good surgical outcome. But child class C, as it is said, that it gives us a poorer surgical outcome at all costs. So the major predictive tool that we have right now, and I commonly use, is a Mayo risk score. It is available freely in the form of applications, mobile applications, and it's also on their website. It takes into account age of patient, ASA, American Society of Anesthetists score, bilirubin, creatinine, INR, etiology of cirrhosis, and it gives this result in probability of mortality in according to in 1 week, 30 days, 3 months, and 6 months. Another useful score that I found out was clinical frailty score. What is frailty? Frailty is a state of increased vulnerability to poor resolution of homeostasis after a stressor event, which increases the risk of adverse outcome. The clinical frailty score is a reliable predictor of the outcomes in this urgent care context. Clinical frailty score of greater than 5. This simple score, which takes into account the patient condition, independently has the ability to predict surgical outcome. And it clearly shows that a CFS of greater than 5 is independently associated with 28 to 30% risk of post-surgical mortality within the first 30 days. So this is the graph which shows the 3-month mortality according to the clinical frailty. So the summary of outcomes. This is the 30-day mortality of patients with the clinical frailty score of greater than 5. And it clearly indicates that the post-surgical outcome in such patients who have a high frailty score, they are that is poor as compared to other patients as well. So now that we decide to go for surgery in patients with chronic liver disease, there was a study published in association of the American Medical Association part of surgery. Pardon me. There was emergency surgery in patients with chronic liver disease. There was a study that was published in Journal of American Medical Association in 2016, which took into account a large sample size of 700 patients with a median MELD score of 14, and the 90-day mortality risk was calculated. It was found to be 30%. Independently with a median MELD score of 14. The odds ratio of mortality increased 1.6 times with every increase of 10 in the MELD score. And the decreased mortality of 2.2 folds with decrease in MELD score of 3 in the first 48 hours following admission. So this study points to the fact that the certain pre-op operations and optimizations will lead to improved surgical outcomes. So the major predictors of risk factors in surgery are risk scoring. We have established pretty clearly by now that MELD sodium, MRS, and vocal pen score point directly to the risks or prediction of risks in surgery. Serum albumin itself can predict this. Child class C poses a greater risk as compared to child class B. Emergency surgery is associated with greater risk. Hepatic resection, cardiac surgery, and major biliary surgeries are also independent risk factors that point towards a poorer surgical outcome. Ascites is also known to be to complicate our patients, but it is not an independent risk factor. But it poses its problems by causing abdominal wall herniation and causing wound dehiscence. Now, coming to the point where we would like to come in contact with our anesthetic colleagues, I would like to point out that older anesthetic agents with higher hepatic metabolism like halothane and enflurane are increased with the higher surgical risk because they have a hepatic excretion which prolongs their action in liver and increases and results in formation of toxic metabolites, which prolongs the post-procedure and anesthesia reversal. So if we see the newer agents like isoflurane, desflurane, and sevoflurane, we see that they have less than 1% hepatic metabolism, so they can be safely used for as a choice of surgical anesthesia in such patients. So pre-operative preparation and post-op monitoring. So as I said that when you admit a patient and you can optimize him or her pre-operatively, the post-surgical outcomes improves directly. So most important, we find out that anesthesia consultation is very important. And always remember, the anesthesiologist is always right. So we have because they take into account multiple factors, including not only just liver disease, other comorbidities like COPD, ischemic heart disease, diabetes, hypertension, or any other form. We should take into account the fluid status, ascites, coagulopathy, hepatic encephalopathy, hypoxemia, hypoglycemia, varices, and decompensation in the form of jaundice. Coming out from all of this theory, I would like this point is directed directly towards our postgraduate residents, where I would like to emphasize the fact we should look at the patient as a whole. Look for comorbidities and the overall patient conditions. The two scores which take this into account are the clinical frailty index and the vocal pen score. If we start using them in our routine practice, this is going to help you predict the post-surgical outcome in a cirrhotic in a very efficient manner. The second point is counseling. I cannot emphasize the importance of this fact. This is the most important part because in a socially bonded society like ours, it is very important to counsel the patient and their family members especially. So sit with the patient and their family and explain to them. Yes, I agree, our patients may be less educated, but sitting with them and explaining to them increases their confidence that you are doing the right thing and it is in their best interest and to the best of your knowledge. So summarizing, and our take-home points will include that the surgical mortality in patients with cirrhosis correlates with MELD and child score and the risk assessment score that I have pointed out earlier. We should always take into account other risk factors like age, ASA score, emergency surgery, hepatic resection type surgeries, and low albumin. And in patients with obstructive jaundice-related surgery, one point I would like to highlight that decompression procedures before a surgery do not improve the post-surgical outcome. So it's a futile practice to do a decompression procedure in a patient who is having obstructive jaundice. The anesthetic of choice in patients with cirrhosis are isoflurane, desflurane, sevoflurane, and propofol, and they can be safely used with the anesthetics advice. And last but not the least, sit with the patient's family, counsel them, talk to them, explain them the nature of disease, and believe you me, they are going to love you for that. With this, I would like to thank you all. Thank you for your patient listening. I hope that Mickey will be happy as you're reunited with his family. and he'll be going home safely. So goodbye, stay home, stay safe, and stay online. Thank you very much.
Thank you, Yasir, for an excellent talk. I'm sure there must be a lot of burning questions regarding to preoperative management of patients with chronic liver disease. As you know, that liver cirrhosis is a very common problem, very prevalent in this part of the world, and so is tuberculosis. So what if we have a case of tuberculosis with chronic liver disease? So management of cirrhosis in a patient with tuberculosis. Another important topic, and for this I would like to invite Dr. Amna Subhan Butt. Dr. Amna is an associate professor at the Khan University Hospital, associate professor of gastroenterology, and she's also the chair scientific committee of the Pakistan Society for the Study of Liver Disease. And I must say that Dr. Amna is one of the driving forces for this annual conference of the PSSLD. So with this, I hand over the mic to Dr. Amna Subhan.
Okay, so till I am sharing my slides with you. So thank you very much, and good afternoon, everyone. So for the next couple of minutes, I'll be discussing a case scenario of a patient with cirrhosis and underlying chronic liver disease presented with cirrhosis. I think this is a very common scenario for all of us, and we do see patients coming with ascites and presenting, and when we work them up, then we found to have underlying tuberculosis. Okay, so just give me a second. My slides are going to be uploaded. And so let me to describe the case till I get my slides. So here is a case of 50 years old male who presented with, who was known to have underlying chronic liver disease because of hepatitis C, and now he presented with 2 months history of abdominal distension and weight loss. So on examination, he was found to be ecteric, and moderate ascites was present. He appeared a little bit emaciated because of malnutrition. So now the question is, what this patient does have, is this ascites because of underlying chronic liver disease, that is like this is because of the portal hypertension, or this is a non-portal hypertension related ascites? And I think this is something we actually encounter every day in our daily practices. So remember, as we say that every encephalopathy is not hepatic encephalopathy, likewise every ascites is not because of the portal hypertension related ascites. So here comes a question that, is this a common scenario to have underlying tuberculosis with ascites, or this is an uncommon condition? I wish I could take your responses directly. You can share your responses in the chat box as well. So what does the literature says about it? So the data is actually available from the different countries. For instance, there is a Danish study where they've said that the incidence of tuberculosis among cirrhotic patients is very high as compared to the general population. For example, it actually has been reported about 14 times higher as compared to the general population. From the Indian studies, 15 times higher. So you may see the variability in the data reported, but most of the studies has reported 10 to 15 times higher incidence of tuberculosis among patients with cirrhosis, and more common in patients with more than 60 years of age and among male patients. Not only that, 30 days fatality rate has been reported about 27.3%, and 1 year case fatality rate has been reported to be 47.7% in such cases. Here is an issue: increased risk, poor prognosis. This is what the data is actually says about it. But why is like that? So the cirrhosis being itself is actually an immunodeficient state, and the cirrhosis is actually reported to be associated with immune dysfunction syndrome, which is a multifactorial process in which the ability to clear cytokines, bacteria, and endotoxins from the circulation is actually affected. This is not like as we have in immunocompetent patient. And why is this like so? So you remember that in the liver, the 90% of the cells of the reticular endothelial system that are central for clearing bacteria, such as Kupffer cells and the sinusoidal endothelial cells, they are present in the liver. In cirrhosis, what happens that these reticuloendothelial system is actually dysfunctioned. Significantly, there is a reduced monocyte spreading chemostasis, bacterial phagocytosis, as well as bacterial killing. There is decreased neutrophil mobilization and phagocytic activity with reduced oxidative burst, and a phenomena that has been shown to be correlated with severity of underlying liver disease. And on the other hand, remember, the liver is responsible to produce various proteins, including the immunoglobulins. So the level is actually affected, and the people do have low immunity. Hyperammonemia and hyponatremia have been shown to be led to reduced neutrophil function and again impaired phagocytic activity. So these are the certain factors. These are actually responsible to make these patients immunocompromised, and they predispose them to this infectious condition. So how does the TB can present in patients with cirrhosis? Just like the immunocompetent patient other than cirrhosis, so there is a subtle difference. There is a subtle difference. For instance, the extrapulmonary tuberculosis has been reported to be more commoner in this group of patients as compared to, and among extrapulmonary tuberculosis, the peritoneal tuberculosis has been reported to be more commoner. And cirrhotics who develop tuberculosis, they are generally decompensated, and majority of them have underlying child B or child C cirrhosis. And here the bacteria are more virulent, there is a low immunity, and they are predisposed to develop drug resistant tuberculosis, and this prevalence of MDR-TB is more higher for such patients. So you can actually observe some differences between other patients and them. So what happened to this patient? So acidic fluid DR was done, which revealed low SAG, high proteinusitis with predominantly lymphocytes. The CT scan was also done because he had a history of weight loss underlying HCV, suspecting HCC. HCC was ruled out. Now what is next? Should we do further investigation and testing, and should we give a trial of ATT for this patient? So the acidic fluid was sent for AFB smear and culture. Is this enough, or should we do something else? So the diagnosis of tuberculosis, especially in patients with end-stage liver disease, is very challenging because many times their symptoms and presentations, they are already overlapping with the presentation of underlying cirrhosis. Sometimes there are no much symptoms, but there is just only an abnormality in the liver function test. So the role of the diagnostic test, for example, the sputum smear and the radiograph in the presence of cirrhosis, these are similar as they are in the absence of cirrhosis. The TB peritonitis possibly sometimes mimics a spontaneous bacterial peritonitis, and in less advanced cirrhosis, the cytic fluid analysis usually shows the lower WBC count, higher proportion of mononuclear cells, and high level of protein and ADA. But here there is a problem. ADA level, which is like quite sensitive for tuberculosis, the presence of cirrhosis may actually reduce the sensitivity to up to 30%. It says possibacillary disease and the smear, which are actually performed on the cytic fluid, they are in general, they are negative. So these are the problems. So if in such cases, so in this patient, for instance, there was the biopsy could be done, but there was no area, for example, peritoneal thickening, where the biopsy could be done. There were low lymphadenopathy. This was just ascites. So as in the absence of any other focal reason, this patient was started on ATT. What he was started on, I will come to that. But that actually brings a question that how should we treat these patients, and what are the challenges when we treat these patients one can encounter? The tolerances in general sometimes is actually poor for such patients. There are higher incidences of hepatotoxicity, and most of them are because of first-line ATT, and which demonstrates the hepatotoxicity, and it actually can lead to the discontinuation of the treatment. And sometimes it is associated with fatal outcome as well, which is definitely a very concerned situation. So the monitoring of the DILI maybe is actually confounded in the presence of underlying chronic liver disease due to fluctuating liver function tests per se because of the existing liver disease. This is another challenge, that whether this is because of drug-related deterioration or this is because of underlying chronic liver disease. Unfortunately, there is still no consensus regarding monitoring and the treatment regimen and the higher chances of, especially in case of MDR TB, for such patients. So we know that these are the first line therapies, and the second line therapies include all of these medications, streptomycin, cyclosporin, and ethaniomide, and all of these medications. So the problem happens when this is the combination of drugs. The individual hepatotoxicity proportions are lower, but they're combined as we do it in patients with cirrhosis, then the chances of hepatotoxicity high. But unfortunately, here is a problem because TB has to be treated by the multiple drugs. So double-edged sword, the treatment may lead to hepatotoxicity, and the progression of TB is actually sometimes lead to the progression of underlying chronic liver disease. So the various proportion and the risk group has been reported in many studies, and this is an overall data that the maximum hepatotoxicity in these studies has been reported with the combination of INH and rifampicin, and higher than that when you combine it with pyrozinamide. So what we can do, there are two principles: monitoring, adequate, and the modification. Whenever you are faced with this problem, how frequently should we should monitor these patients? So the recommendations are actually different. For instance, Indians guideline recommend different. ATS and ACG is actually they recommend different. But in general, the people says that if this is 3 to 5 times elevated, then we should be very, very concerned about it and modify the regimen or decide about a second option. So these are the 4th edition of WHO guideline, and what they have recommended. It's the most preferred regimen they recommend is without PZA. And without PZA, then what you can offer 9 months of isoniazid and rifampicin and ethaniomide, or 2 months of isoniazid, rifampicin, streptomycin, and ethambutol, followed by 6 months of isoniazid and rifampicin. And likewise, these are other options. For instance, you can have like one hepatodrug. If you want to go or as actually for a high risk patients, one hepatotoxic drug, for example, in patients with child C cirrhosis, then you can adopt these two type of modalities. And for instance, if somebody is like really high risk and already has encountered the problem of DILI because of ATT, then without hepatotoxic drug 18 to 24 second line therapy, you can actually use this regimen. So this is one recommendation which actually has been recommended by Sunika et al. And what they said that for child's A and MELD score of less than 18, to potentially hepatotoxic drug, you can start with that. And if the patient will tolerate, you can is actually then top it up with the further drug. In case of child's B, so you can start with one potentially hepatotoxic drug, and then you can adjust the medication if the patient tolerate well. But if very decompensated patient, no hepatotoxic drug, better to avoid them. So this is again like if you want to avoid these medications, all hepatotoxic, then these will be the combination you can is actually use. So how do you define hepatotoxicity, and when you will actually intervene and you will modify? So the most of the experts is actually recommend, and the literature supports that if the ALTs are like 3 to 5 times elevated, then is actually you can consider modification of the therapy. And again, if the bilirubin is actually more than 2.5 times elevated, then again you can consider the modifying the treatment and holding for a while and then restarting it. So restarting the therapy. So how can we do that? So this is one algorithm which has been offered by a few experts. Here what you can do is we should check as actually the transaminases and liver function tests at the baseline, and we should keep following monitoring them intermittently. So to begin with, you can monitor them as per like few literature recommendations. You can monitor them to begin with twice a week or at least once a week. And if they are like quite well within the reasonable range, then you can follow them weekly for 4 weeks, and followed by you can increase the interval depending upon your clinical judgment, and then after every 2 to 4 weeks you can keep them repeated. So what happens if this is very elevated? For instance, the AST and ALTs are like more than 5 times elevated, or bilirubin is more than 2.5 elevated, then this is very, very diagnostic for the drug-induced liver injury. So here what you need to do, need to stop the medication and give some time, wait till they return to the baseline, or at least less than 2 times of the upper normal level of ALT. So this is again very important, that for how long you will be waiting. So just wait, at least they will become normalized, or at least they will be less than 2 times of the upper normal. And here then you can restart step by step. For instance, you can start with rifampicin in the low dose, followed by adjust the dose according to the weight, and once the patient is actually tolerating it very well, then you can move to the second first line therapy, for example the isoniazid. And if the patient tolerate it very well, then you can add is actually rifampicin, you can as actually continue, you can add the third medication as well. And with all of these things, ethambutol is like relatively least hepatotoxic drug, then you can add the ethambutol either right from the beginning or after starting the rifampicin. So this type of algorithms are actually offered in the various consensus papers and all, and you will find some variability. But the basic principle is a start from one hepatotoxic drug and then move to the next, and then if tolerated well, then the next and the next and the next. So in summary, so TB treatment in patients with cirrhosis is challenging. And this is because the TB per se can lead to dysfunction of the liver, and whether this is because of the underlying liver disease or this is because of the ATT, differentiation sometimes get very challenging. But frequent monitoring and early detections are the mainstay to prevent the drug-induced liver injury in these patients. Successful reintroduction of ATT is possible. So I thank you very much for your kind listening. Thank you very much.
Right. Thank you, Dr. Amna, for an excellent talk. I'm sure there must be many questions regarding this. We'll take them at the end. So if we can have Professor Sadik Memon online. Is he online? Okay, thank you. So we move on to the last talk of this symposium, number 3A. And this case will be presented by Professor Sadik Memon. And Professor Sadik Memon is a consultant gastroenterologist and hepatologist at the Asian Institute of Medical Sciences, Hyderabad, Pakistan. He will be discussing about a case of overlap syndrome. So over to you, Professor Sadik.
Can you hear me?
Yes, we can hear you, sir.
Okay. Bismillahirrahmanirrahim. I am Dr. Sadik Memon from Hyderabad. I am grateful for the organizer, Professor Yasir Abbas and the Madam Amna Subhan, and the other organization to give me a chance to say something about the overlap syndrome. What I will discuss about the case vignette, I will discuss the diagnosis, I will discuss the available treatment on the globe, and a recent meta-analysis on overlap syndrome, and finally I will give the conclusion and the future prospects of the overlap syndrome. I am thankful for a few slides which I am taking from Mr. Bruce. The first slide is 45 years. These are 45 years old female present with the persistently elevated ALT and AST and normal alkaline phosphate and bilirubin. The symptoms were fatigue and the joint aches. ASM was also positive, AMA negative, ALT 175, AST 120, alkaline phosphate normal. Liver biopsy was offered, it was corrected, followed by she was put on the Emiron. The same patient is continued, liver enzyme was normal within 4 weeks, patient feels well. 5 years later, the routine follow-up, the alkaline phosphate now elevated is 280 and the bilirubin was 1.8. We did the ultrasound and we did the other tests, hepatitis B, C, and the evaluate for the fatty liver as well. We couldn't find anything. Finally, we offered the liver biopsy of the patient, and the patient accepted liver biopsy and we did the liver biopsy. This is the liver biopsy, which is a very classically showing the bile duct proliferation and also some element of the interface hepatitis. So you all, I think you all picked the diagnosis as well. This patient is developed primary biliary cirrhosis. Previously was treated with for the autoimmune hepatitis. So what we did, we added the ursodeoxycholic acid 600 milligram twice a day and follow up all the laboratory tests which become normal within 6 months. The case 2, a 45 years old lady complained of pruritus, elevated alkaline phosphatase, fatigue, and the joint pain. AMA was 1:320. ASMA was negative. ANA was positive. She has ANA was positive and LT was 48, AST normal, alkaline phosphatase was 220. A liver biopsy was characteristics of the PBC. She was treated with initially with the ursodeoxycholic acid 600 milligram twice a day. Patient was on follow-up. Alkaline phosphate become normal within 8 weeks of treatment. She was feeling weight. Down the road, 5 years, as again ALT and AST become elevated to 130. We did the workup for hepatitis B, C, ultrasound, and the other tests, which all will become normal. We offered to the liver biopsy to the patient, but unfortunately, patient was refused for the liver biopsy. So we start empiric treatment. We put her on prednisolone initially and taper the steroid and then put on Vimiron. Within 2 months of the follow-up, her AST and LT become normal. The third case, the 45 years female complaining of fatigue and pruritus. Her ALT was elevated, AST, alkaline phosphate, all were elevated. ANA was positive, ASMA was positive as well. A liver biopsy features of both PBC and autoimmune hepatitis. She was treated with the trial of initially urso, but her some labs were responding, the other was not responding. So she was again put on prednisolone and it was tapered and she was finally put on Imiron and urso. She was on the combination treatment. My fourth case is the patient, is a gentleman, 39 years old gentleman, is a known case of ulcerative colitis. For 6 years on follow-up LFTs, the LFT showing that alkaline phosphate and gamma GT was raised and ALT was AST was normal. And the ANA was 100 to 60 and increased gamma globulin as well. Yes, we did his MRCP, which showing very typical beaded appearance. The patient was offered for the histopathology. On histopathology, we found that this gentleman has a classical finding of primary sclerosing cholangitis along with the interface hepatitis. So this is our fourth case. So you have seen all these cases are the cases vignettes of the overlap syndrome. So what is the overlap syndrome? Overlap syndrome is used to describe a family of rare morbid condition characterized by the biochemical, immunological, histologic, or cholangiographic feature of more than one of the well-recognized autoimmune liver disease. So overlap syndrome, whenever you have more than one autoimmune liver disease in the liver at one time. So these are the autoimmune diseases, are the autoimmune hepatitis, primary biliary cirrhosis, cholangitis, primary sclerosing cholangitis. These overlap syndrome may present as autoimmune hepatitis and PBC, autoimmune hepatitis and PSC, PBC, PSC, autoimmune hepatitis and PSC and PBC, autoimmune cholangitis and autoimmune sclerosing cholangitis. While their initial presentation is differ, sometimes they have very minimal presentation, sometimes they present with a very severe disease, but all ultimately progress to the cirrhosis of liver and its sequelae. So this is the graphical picture of the autoimmune hepatitis along with the PSC and the PBC. What is the how they present? Some patient begins as a pure autoimmune hepatitis and acquire PBC later, as our first case. Some patient begins as the PBC and acquire hepatoimmunity down the road in our second case, and the third case when both disease present at the same time as in our third case. What we have? Do we have any diagnostic protocol or development any scoring system? Yes, we have a development of scoring system for the overlap syndrome, and information we have gathered from 105 studies on autoimmune hepatitis, 102 studies on primary biliary cirrhosis, and 65 case reports, case series, and various studies on overlap syndrome. Based on this, a scoring system has been developed, and this is the same international autoimmune hepatitis scoring system, but here the scoring is very high. If you score more than 21, is a highly likelihood of the overlap syndrome. If it is less than 19, then it's less likely to be a overlap syndrome. So what is the score system? It's the same as the autoimmune hepatitis international group. We have the numbers for ALT is less than 2, twice in normal, then 3, then 1.5 is 2. But the one thing is very important in autoimmune hepatitis group is AMA is positive, then the score is -3. But here for the overlap syndrome is AMA is positive is plus. Another thing is that if the bile duct injury in the autoimmune hepatitis is there, then the chances of autoimmune hepatitis is decreased. But in overlap syndrome, if the bile duct injury is there, it's again has the +1 marking. So that is the reason this scores is based on this. His scores is very high. If you have more than 21, is a definite for the overlap syndrome. So this is the international autoimmune criteria, and the score is more than 15. Patient can be, the presentation of the overlap syndrome, they can be very much complicated, and the generally very gratifying treatment. When you combine both treatment, the response rate is very good. And usually treatment is well tolerated, both ursodeoxycholic acid and also the immunosuppressive agent as well as the steroid. First of all, we will discuss the autoimmune hepatitis, the primary biliary cholangitis. Autoimmune hepatitis and primary biliary cholangitis overlap is mostly studied. Nearly about 1 to 3% of the patients who are suffering from primary biliary cholangitis, they have autoimmune hepatitis, and 7% of the patients with the autoimmune hepatitis, they develop the primary biliary cirrhosis. The Paris criteria, which I will discuss, is mostly widely accepted means of diagnosing autoimmune hepatitis and PBC. The treatment of overlap syndrome, you remember, this is guided by the small observational studies. It's not by the randomized controlled trial or anything, and the data have never been synthesized in a rigorous quantitative manners. So autoimmune hepatitis and the PBC continues the ursodeoxycholic acid and the corticosteroid with or without azathioprine, often having the increasing result. These are the various studies showing the increasing result with the combination therapy. Few studies reveal that benefit with only ursodeoxycholic acid or just only steroid. Ursodeoxycholic acid has been augmented with tacrolimus, mycophenolate, and cyclosporins as a second-line therapies with some success in patients who are intolerant or unresponsive to corticosteroid or azathioprine. What about the down the road this overlap syndrome? 10 years progression to cirrhosis among nearly about 44 to 48%. So nearly about half of the patients who are suffering from overlap AI, IH, and PBC will develop this cirrhosis. And the transplant-free survival in overlap syndrome is 52 to 92. Do we have any comparison data with the parent disease? Yes. The prognosis of overlap syndrome is usually worse as compared to single parent disease. One cohort of a study in 20 studies showed death and the LTX in 38% of the autoimmune hepatitis plus PBC versus only PBC is nearly about 98% death, or the patient is referred for the liver transplantation if they are suffering from only one disease. And this is the 6-year follow-up studies. A 26-month follow-up study is showing that 33% liver-related death and the LTX with autoimmune hepatitis and the primary sclerosing cholangitis versus autoimmune hepatitis, 8% in the autoimmune hepatitis. So this is the definite data, but one thing is that this is the data is observational and no randomization on the treatment arm. So one thing is that overlap syndrome has the worst prognosis compared to the parent disease, only one disease. What are the treatment recommendations for double SLD and EASL? The treatment recommendation for EASL and for the overlap syndrome is in autoimmune hepatitis is sparse and reflecting the thin basis of the primary evidence. For example, the EASL 2017 PBC guidelines state that patients with PBC and typical feature of autoimmune hepatitis may benefit from immunosuppressive treatment in addition to ursodeoxycholic acid, and recommended that the immunosuppression be given or considered in patients with severe or moderate interface hepatitis. So you have to have an interface hepatitis in the liver biopsy before considering the steroid or the immunosuppression. The ASSAULT guideline on PBC concedes that clinical benefit and harm of adding immunosuppressive medicine to the PBC patient with autoimmune hepatitis feature require further studies and recommended tailoring pharmacotherapy on the basis of the severity of the histological pattern of the injury. So though this is the same as the statement of the easel, but the presentation is one of the other way. What about the autoimmune hepatitis and the PSC recommendation? The recommendation of 2010 PSC guideline assault corticosteroid and other immunosuppressive agent, while the acknowledging that the impact of this medication remains unclear. The EASL 2015 autoimmune guidelines further recommended the addition of urso deoxycholic acid to immunosuppression can be considered, although it is difficult to draw any firm conclusion because of the small number of patients and usually retrospective nature of the studies and the heterogeneity of the regime. So combining two drugs, again we have less number of studies because of the less number of patients. We have very less number of patients with autoimmune hepatitis and the primary sclerosing cholangitis. Now coming to 2020 meta-analysis, treatment of overlap syndrome in autoimmune liver disease, a systemic review and the meta-analysis. This is the Benjamin Friedman, and this meta-analysis of the all medication used to treat autoimmune hepatitis PBC, autoimmune hepatitis with PSC. We have 20 studies and 402 patients. Here are 2 studies and 20 patients. The PBC and PSC and other diseases as well. Comparing the efficacy of different treatment regime for each overlap syndrome as measured by the symptomatic, number 1, number 2 biochemical, number 3 histologic, and the transplant-free survival outcome. So we will discuss one by one. First of all, the symptomatic, and then the biochemical and other. So symptomatic improvement, comparing the single drug with the double drug or the combination drug, there is no benefit of combining 2 drugs as far as the symptoms are concerned in autoimmune hepatitis and PBC. Biochemical improvement, obviously if you combine urso and steroid, you have more biochemical improvement, you have more non-progression of the liver fibrosis, and you have more transplant-free survival if you combine the 2 drugs as well. When comparing the urso and steroid plus azathioprine, more of the biochemical improvement with the combination therapy and also the liver transplant-free survival. This is the meta-analysis, and this is the forest chart, which showing these not much benefit with the symptomatic etiology if you combine with the 1 drug or 2 drug. This is the biochemical studies, and we have a biochemical improvement, and we have 13 studies, and the forest, the graph is favoring the combination treatment. This is the non-progression of the fibrosis. Again, the graph is favoring that the combination treatment is better in the non-progression of the fibrosis. This is the transplant-free survival, again showing the urso corticosteroid along with or without azathioprine is better in transplant-free survival. So the clinical outcome of autoimmune hepatitis and the PSC, neither study was, we have 2 studies for meta-analysis, but neither was individual meta-analysis, and the majority of data on combination of steroids and the azathioprine. No definite of biochemical improvement, but for the biopsy improvement has been seen. Total patient in 2 studies by Luth and McNair was only 20. So it's very difficult to make any precision on these 20 patients. Quality of evidence which we have gathered for the overlap syndrome, the majority of studies on the overlap syndrome are observational and difficult to make any grade on the basis of this marginal improvement. Another common limitation with this studies for the overlap syndrome is imprecision due to suboptimal information size, which affected also the meta-analysis. So what is the conclusion overall regarding the overlap syndrome in December 2020 for the management of how to manage the overlap syndrome in 2020 December is that ursodeoxycholic acid, immunosuppression, or a combination of both have been used as the first-line therapy for the overlap syndrome in autoimmune liver disease, but the evidence supporting one regime over the other is sparse. You can treat, but we have very small evidence. Benjamin systemic review and the meta-analysis showed no clear difference in the clinical outcome between these treatment regime and any of the examined overlap syndrome, although the quality of evidence was very low. what is the future, what we have in the future, while waiting more definitive studies in the future, providers or the hepatologists should continue to rely on the professional society guidelines as well as the expert opinion in the treatment of these rare disease. So this is all about my talk. Thank you very much for your kind listening. The bottom line is that we have very small data, very less number of studies on overlap syndrome, and the data is that overlap syndrome should be treated by a combination of treatment. If the patient has autoimmune hepatitis first, you can use URSO if they develop PBC or PSC. If a patient has PSC or PBC and develop autoimmune hepatitis, you can add steroid initially and then change to the immunosuppressant therapy. Thank you very much for your kind listening.
Thank you, Professor Sadik, for a very nice review. I think we have come to the end of our session. It was a pretty hectic and heavy set of talks. So I would now request that the presenters maybe they can just briefly maybe a couple of lines or a couple of sentences to round off their talks so that we can have the bottom line message from each of their talks. Maybe we can start from Dr. Faisal Waseem. Dr. Faisal, are you there?
Yes, I am.
Yes. So please, could you just summarize whatever you discussed in terms of gastric variceal bleed refractory to endoscopic therapy, maybe?
Well, the point that I was trying to make today was that gastric varices should be thought of as different from esophageal varices. Whereas esophageal varices can usually tend to bleed a bit, but they settle when the pressure inside them gets relieved. That does not happen with gastric varices. If glue therapy fails in gastric varices, the usual situation is a bad one where the varix just continues to bleed unless something is done about it. And in that situation, what is best to be remembered is that we should consider that intervention radiology should be the way forward. I don't think if people have do not have the expertise or do not have the balloon tamponade measures, they should not waste time on that, but consider VIR. And in VIR, the best thing to do would be TIPS. There is a role for BRTO. It should be reserved currently for those patients who are not candidates for TIPS. But if endoscopic therapy fails, TIPS is the way to go.
Right. So in this regard, I have a question for you, Dr. Faisal. What do you think of ectopic varices, the varices which are present beyond the stomach and into the small intestine, maybe somewhere in the jejunum or duodenum? So how do you think we can effectively manage ectopic varices both endoscopically and beyond?
Good question, Kamran. And the way and we all know that it's usually extremely difficult to diagnose an ectopic varix bleed. And just because you see the varix doesn't mean it's that particular varix that has bled unless you actually see it. But if it's in the range of your scope, whether it's your upper GI scope, doing an upper GI with a colonoscope or even an enteroscope, if it's in the range of your scope and you can put in a catheter down that, then essentially you deal with it the same way that you deal with the gastric varix, which is the injection of N-butyl 2-cyanoacrylate, even ethanolamine.
Right. So I think we can move on to Professor Arif. Maybe, sir, you have something to say about, and then we'll take questions.
Screen just froze. Can you hear me, guys? So
yes, we can.
I think I don't have to go through that.
Yeah.
So basically, just a quick message. Think of Budd-Chiari syndrome, and you can think of it in pretty much all settings, which is acute hepatitis, acute liver failure, or even chronic liver disease. This is something is fairly common, and when you do suspect Budd-Chiari syndrome, look for an underlying cause, and usually it's a hypercoagulable state, and the conventional hypercoagulable states that we have been thinking about, I think we need to go beyond that. There are other conditions like factor V Leiden deficiency, myeloproliferative disorders, and the JAK2 mutation to look for them. So it's very, very important to think about this because the treatment can be the difference between life and death. Just a quick question from Zagam, since I have the privilege of having some excellent people around. This injection of ectopic varices, I think is a very good, you see them all the time, you see them with their duodenum. I personally, I think I have injected one varix in somewhere in the rectum. She was just profusely bleeding out, and I used hysteroacryl, and a few months down the road, the patient is still alive. I mean, several years down the road, she's still alive and fine. But anybody else has an experience? I mean, Nadeem is also on. Nadeem, are you there? But anybody?
Yes, I think Dr. Nadeem is there.
Yeah.
Okay, I think Dr. Amir has brought up a very important point. So just a quick reflection. So during my first year of fellowship, we encountered with a young gentleman who presented with a massive upper GI bleed, life-threatening, intubated, variceal band ligations were done, and there was a bleeding spot present. Within 12 hours, he bled again. We did a relook endoscopy. He was not bleeding from esophageal varices, but he bled so much that he became hypotensive, and we developed shock. And standing behind the faculty and just thinking what's happening with the patient, and I thought, are there any rectal varices? And my faculty exactly said, Amna, tum to pata nahi kya sochti rehti ho. And this is a weird thought. Why somebody will be bleeding from two different sides? And I thought, okay, as a year one, I can think weirdly, possible, quite possible. But then when we didn't find any underlying cause, then we did a sigmoidoscopy, and there were the rectal varices sitting there. So injected, and the patient did well. So after 48 hours, he was out of the ventilator and all, but this is not that common, but this is something we should all remember, and we can face this problem, and you can inject hysteroacryl over there.
One other thing I want to tell my younger colleagues, and now I have the privilege of calling some people younger than us, because Jagam and I are sitting here from way back.
We feel good after that.
Yeah, I know. So one of my biggest advice to the younger, newly starting people is that treat gastric varices with a lot of respect. When these people go south, they go really quick. I think one of the only patients I've lost in an upper endoscopy was a gastric variceal bleed. I mean, 90 cases will go well. You will keep on injecting them, and no problems and everything. And one case will just crap out on you, and it will shake your confidence. So please be very, very careful. Our routine to ye thi ki we even would arrange blood for these guys before injecting. And everybody would say, why are you doing that? My second advice to you is they should always be on a cardiac monitor. Subha, there was a lot of discussion about these people embolizing everywhere. I have personally witnessed a VTAC right in front of me injecting gastric varix. Yasir doesn't feel that ye zyada embolize karte hain, but I generally feel that they always embolize. They start coughing, which is a sign of a pulmonary embolism. So please treat gastric varices with a lot of respect. Do it in the right setup. Everybody doesn't have Faisal. So if these people crap out, they crap out. Or I think Blake mode, all said and done, it's a desperate measure, but might be helpful if you have no intervention radiology, which most of us don't.
Yes, if you take X-ray chest after you have embolized this gastric varix, you will see what happens if you have used a lipoidal. So I stopped using lipoidal, so I just mix it with distal water. One advantage of mixing it with distal water is that crystallization occurs very rapid. But this gives enough time to get injected into the varix. So this is so you may get you may lose your this injector, because some crystallization may occur in the injector as well, and you can always use second injector if you want to inject second time. So what I have been practicing after seeing these X-rays and episodes of embolization, so I just mix it with distal water, equal amount, and inject it quickly.
Yasir uses vitamin D. Yasir, you want to say something on that?
Yes, I completely agree with Professor Zegam sir. We commonly use two options. Either it is it's distal water, or recently we've started and shifted to using vitamin D as a
yes, people have used this olive oil. People have used this vitamin D. My only problem is these are the fat soluble agents, and they take away this glue away from the varix also, just like lipoidal, and chances of embolization are there. We also have glupron, and we have injected a few times glupron also, which is crystallizes slow and does not require any lipoidal mixing.
Recently, the rising prices of lipoidal and limited availability that has led us away from using lipoidal, and these are just our replacements for this this procedure. And alhamdulillah, it's so far so good, and let's see what the future has in store.
And how many of you are missing ethanolamine? You remember, if life-threatening esophageal variceal bleed, you can inject and then you can control it. So how much are you missing ethanolamine?
Took me back to first year.
Any of the sclerosing agents, in my personal experience, has been fine. When this desperately something is bleeding, just inject anything and it works. I've injected 25% dextrose, we have injected ethanol, all sorts of things. Those are desperate times, so whatever you have.
Yes, but I think ethanolamine oleate is not available now. We do have STD, sodium tetracetyl, what do you say?
Tetradecyl sulfate.
Sulfate, yeah, STD, yes, that is available, but ethanolamine oleate is not available.
Yeah, but it's good that it is not available anymore, those crazy esophageal strictures that you got after that. So thanks God we don't see them anymore.
Can I ask Sadik, one of the most practical, one of the very practical questions with autoimmune hepatitis is, what workup do you send on these people? I mean, there is somebody with abnormal LFTs, you think, and we are labeling a lot of people as NASH and all those things. I don't think we sufficiently rule out autoimmune hepatitis. So can you tell us in our setup, what is the practical testing that these people should get done?
Thank you very much for asking me. What we are doing, we have availability here is one is the ANA, other is the anti-smooth muscle antibodies, and anti-mitochondrial antibodies. And sometimes still if they are equivocal, so we can do LCAM antibodies, immunoglobulin, IgG we usually do. So these are the tests. I also reviewed the literature recently. Most of the people are doing these three tests. Number one is ANA, ASMA, and AN. And if they don't have the answer and still they are very highly suspicion of the patient having the autoimmune hepatitis, they are going for the LKM, immunoglobulin G. Obviously, immunoglobulin G is also whenever you suffer, considering, but the other autoantibodies are not much prescribed to the patient on the first time whenever they are just suspecting the autoimmune hepatitis. And I have recently reviewed the literature as well, and there's a good number of patients in which no autoantibodies was positive, but the patient had interface hepatitis. And a few of the case reports where they have treated with the steroid and the azathioprine, the patient will come very well, and the response very good.
Sadik, there are few laboratories in Pakistan. They are doing autoimmune liver panel, which includes 9 to 12 antibodies, and what I have found is that AN-ASM is negative. Some of these antibodies are positive, like SP100 or GP210. So you are able to diagnose more and more cases of autoimmune liver disease now. Actually, this is a spectrum of diseases. If you see primary biliary cholangitis, how patient becomes cirrhotic. This is because the inflammation goes from the portal tract outside. It involves the limiting plate, and it ends up with some sort of interface hepatitis. So, if the primary biliary cholangitis remains up to the portal tract, patient should not become cirrhotic. This is very logical. So, there is some element of overlap is always there. That's why up to 5 times the upper limit of normal ALT, which you see in these patients, you take it as a case of primary biliary cholangitis. You don't label it as autoimmune liver disease. So, there is some overlap, but sometimes this overlap becomes more severe, and you see more overlap from primary biliary cholangitis to autoimmune hepatitis. That's why if you see in the current studies, they do show that steroids do help even in patients with primary biliary cholangitis. As a second line, if you also is not working, and if you also immunosuppressive therapy do work when you see elevated ALT in primary biliary cholangitis. So there is always a confusion, how much should we give credit to the overlap, whether this is a primary disease. So there is enigma is always there, and you mentioned about these new overlap criteria. So let's see how these criteria become validated later on.
What is your threshold for a liver biopsy? I really feel that if you're labeling somebody for lifelong disease,
Yeah, the only problem with the liver biopsy, I mean, if you do the liver biopsy, you do not get your answer. Like plasma cells, you are interested in looking into plasma cells, you are not able to get those plasma cells, and you are not able to get interface hepatitis like you expect in cases of autoimmune hepatitis. Either this is a problem with the biopsy, number of the prototypes are not sufficient, or so there are many problems that are there, and clinical acumen and clinical decisions still weighs a lot in deciding whether to give steroids and immunosuppressive therapy.
I agree with Dr. Zagam because in chat box, Dr. Amjad Salamat mentioned about how about the Paris criteria. Yes, that's useful, but many times things are so overlapped, then you're using a clinical judgment. But on the other hand, combining all of these data and discussing sometime the histopathology with the histopathologist is actually helps. So these difficult situations, but definitely one can think about.
Nadeem is there. You can say anything about everything.
So no, I think it was a really good session. Lots of learning. Few points that I would like to share on point of overlap syndrome. So I think I completely agree with the opinion that we should consider biopsy early, especially if you have any doubt about the diagnosis. Majority of the time, the diagnosis will declare itself if you follow those patients for enough length of time. Before labeling a patient as an overlap syndrome, I think it's probably wise to have a second opinion from another hepatologist. As Professor Yasir Abbas was earlier alluding to, so things like you can't rely on the initial histological criteria that used to be a standard, for example, kind of interface hepatitis, and there is going to be some form of inflammatory activity because essentially this is the same spectrum of disorder. So before labeling them as overlap, it's probably best to have a second opinion. It's probably important to follow them for a certain length of time because the original disease will declare itself, especially in the younger patients, because you then have to decide on those patients taking lifelong, in some cases, immunosuppression. So it's really important that those things are clearly documented and diagnosed from the onset. I think the cases that you discussed were really educational. In cases of PBC, we don't tend to go for liver biopsy when we initially diagnose them. But I appreciate in some cases you certainly have to consider biopsy if you've got initial diagnosis, if there's a doubt about the initial diagnosis. For second point, from the pre-operative mortality point of view, I remember there's a colleague of mine who was contacted by one of the surgeons so he received a call from a surgeon who were operating and essentially had a patient's tummy open. And what he said to him that, look, mate, I've got a patient in front of me who I opened for gallbladder, but his liver looks quite knackered and cirrhotic. So my colleague's reply to him was, why don't you take his liver out then? So it's essentially what you have to. So I think that's a difficult area, but very nicely covered. The important thing from my point of view, or the thing that I look at, what is going to kill a patient. So if a patient comes who's quite sick and needs an intervention, he needs an intervention. One of the important things that we should, I think, inculcate in our juniors when they are discussing cases with us, it's not about cirrhosis. Patients who decompensates are not those who have cirrhosis. Those are the patients who decompensate are the ones who have underlying portal hypertension. So assessment of portal hypertension is probably far more important then you have to take into account their ASA status and other comorbidities and the overall performance status, frailty. But what is also important, which should be taken into account, is the degree of the portal hypertension, because it's the portal hypertension which obviously from surgeon point of view, the risk of bleeding intraoperatively and also the risk of decompensating following surgery. So that is quite important to be taken into account. I think that's all I wanted to say. So thank you very much for another fantastic session.
There's a question for Dr. Arif. Sir, in Budd-Chiari syndrome, what is the long-term outcome after TIPS? And how many patients need liver transplant after TIPS? So this is a question from...
Maybe Faisal is still here. Maybe you can answer this, because again, remember, TIPS is a bridging procedure. The way, however you look at it, it's a bridging procedure. It's not a definitive procedure. So if the prognosis will depend on the underlying liver disease. So if it's a significant, the prognosis is the same with what if it's cirrhotic or decompensated cirrhotic. So again, it's a bridging procedure. I want to emphasize that, not a definitive procedure. Keep on looking for the cause, treating the cause, underlying cause.
And there's one more question regarding this. After how many months post liver transplant, anticoagulation should be stopped if all thrombotic workup is negative? So this is the question which has come.
I think you'll have to do a functional assessment of these patients, and I'm really not the expert at this. Do you have a comment on that? Because, yeah.
Actually, this all would depend on the thrombophilia profile of the patient. Like if you had the protein C or protein S deficiency, and this was a part of Budd-Chiari syndrome, then this is being taken care of after the liver transplant. But having said that, I think prolonged anticoagulation would be required. I am not expert in dealing such post-transplant cases. Nadeem is there, but these patients do require, and this all depends what was the baseline pathology that ended up in Budd-Chiari syndrome. And if there is genetic predisposition for persisting sort of etiology, then we'll have to continue with the thrombolytic therapy.
Nadeem, the question was post liver transplant. How long would you want to continue anticoagulation with people who have underlying hypercoagulable states?
So I think I completely agree with what Professor Yasir Abbas was saying. So majority of those patients will have some form of neoplastic process going on. And if it was the neoplastic process to begin with, then you end up suggesting anticoagulation lifelong. Otherwise, it has to be guided by the hematology based on their underlying thrombophilia profile. But yes, it's important. Once they have TIP, you end up giving them a form of anticoagulation lifelong.
Like you see cases of homocystinemia, you see cases of JAK2 mutation that you present to with Budd-Chiari syndrome. So there are some problems in these patients, and the patient will require long-term anticoagulation.
If Faisal is still here, my question was about webs. How often are you seeing them, and how do we suspect them clinically?
Unfortunately, Dr. Faisal is probably offline.
He's
He's committed somewhere. Yes.
Okay, so for the webs are like among the common etiologies in Asia Pacific region. The largest data has been reported about the webs causing Budd-Chiari syndrome has been from Nepal and other countries. Professor Anand Shrestha has written lots of reported the studies and about non-cirrhotic portal hypertension and about that. In the rest of the world, the data is limited. It's infrequent, but this is not a very rare entity. And there are feelings that sometimes this is underdiagnosed because you need venography or all of these things to diagnose the presence of web, and sometimes they are missed and not actually reflecting the true prevalence of this underlying problem.
So there are bacterial causes also. They have recovered bacteria that end up in production of webs in the inferior vena cava. So.
Membranous obstruction can ultimately make you prone to HCC, and I don't know the pathophysiology behind it, but people who are studying for the exam should just keep it in mind. They will say MOVC could predispose you to hepatocellular carcinoma, so just a pointer.
Right, I think we had a wonderful session. I would now request our chairs to quickly round up the session so that we can move on to the quiz. I think that was one of the favorite parts of the sessions, right? So, Dr. Rustom, I think...
Thank you, Dr. Kamran. This was a really exciting session, and here we have discussed very important and common vignette which we come across in our daily basis, and I am sure that the audience has been benefited from it. And I would like to thank the presenters for bringing this evidence-based literature for our audience. And thank you very much. And I would also ask my co-chair people to wind up their thoughts.
Dr. Nadeem, would you like to say something just at the end?
No, I'm very grateful for the opportunity. I think it was a really exciting session and we all learned a lot. Thank you.
Right, thank you. We have a couple of chairs more. Dr. Abdul Qadir, is he online? Is he with us? And Professor Masroor Ahmad. Okay, so I think with this...
My name is Masroor Ahmad.
Yes.
Can you hear me?
Yes, sir, we can hear you, sir. Please go ahead.
Thank you very much for asking me to chair this session. I wish this discussion would have gone a bit further, लेकिन असर का नमाज का time हो रहा था. It was a wonderful, very wonderful, and there were so many important covered, especially Amna, you have covered tuberculosis. It's very common in our setup, and this question at least once or twice in a month we are facing with the problem what to do, and you have definitely given a very good insight what to do with these type of patients. Yasir, excellent. The surgical people, whenever they see anti-hepatitis B surface antigen positive or anti-HCV positive, go to the hepatologist, go to the physician, and we say, "Bhai, ye to it's a compensated case. Why don't you do?" Or he said, "No, you better treat hepatitis C and then come later on." So as Nadeem has said, when there is an intervention is needed, has to be done. Waseem, I'm sorry, I was entangled in the net at the time when Waseem was talking, so I missed a lot. I enjoyed Arif Saab, and I always enjoy Arif Saab, and he's as excellent as he was. Always, when we have met previously, I was in fact intending to be there physically, but because of COVID, I cannot come. I don't want to infect other people. And definitely, my friend Sadik, we talked about something which is rare, but we have to keep in our mind. And yes, I can add one thing, that when there is a protein C or protein S deficiency or antithrombin C deficiency, this is an indication for a lifelong anticoagulation for these patients, and that has to be balanced with his hepatic condition and needs to be a very vigilant hepatologist as well as a hematologist to look into. So I am really thankful to the organizers. It was a very, very excellent session. It gave us a lot of knowledge. Thank you very much, all of you. Allah aap sabko khush rakhe. Assalamu alaikum.
Thank you, sir, for your valuable comments. At the end, I would just like to move towards the quiz now. Yes, can somebody from the IT please? Okay, so, right. So, this is the first question. A 26-year-old lady who presented with 3 weeks history of abdominal distension and pain. Okay, so the ultrasound is showing an enlarged liver with ascites. The ascitic fluid protein is 3.6. Well, the answers have already started coming in. So, Yusuf, I think. Okay, so Dr. Yasir has not done it.
Dr. Yasir is actually withdrawing in like for Farheen, and the Farheen is a winner. Hey, Farheen.
Okay, so Dr.
Congratulations.
Farheen, right, so.
Once again, Yasir, thank you very much.
At least the message has gone through कि even Yasir got the answer right, you know. ये नहीं कि मेरा lecture कामयाब हो गया. Thank you very much. Yasir, well done.
Okay, so the next question, can we have the next one? Yes. Okay, so the answer is already there. So it's a 56-year-old male with hepatitis C related chronic liver disease. He presented with hematemesis. He underwent endoscopy which showed a fundal varix. It was obturated, and after 24 hours he again had a massive bleed, and this time he was hemodynamically unstable. So next step is, of course, well, we have the answers. So no, Dr. Farheen. Well, I think it's C.
What is the correct answer?
The correct answer is C.
Correct answer is C.
I think it's Mohammad Kamaluddin.
He's at 426.
Yes.
He answered for the previous question? Okay.
Oh.
So Farheen again. Farheen
No,
again, Yusuf?
Mohammad Arsalan, I think.
Farheen Lubna Hashmi.
the start of this question. These are the previous question answered.
What about Muhammad Arsalan? I think he also answered at the same time, maybe a little bit early.
But you can follow the queue.
Okay.
Yeah. Because it's like millisecond difference.
Right.
So Farheen is like on the top, followed by Muhammad Kashif, followed by Jalpa and Arsalan.
Okay.
So the first correct is, so jury is for Farheen.
Dr. Farheen, so keep the second one for me. Right. So I think with this we wrap up the session, and good to see you all.